Oh, I love that it naturally gets more silent. We were talking about what a big group it is today. It's really, really nice to see everyone. So truly my pleasure to introduce our visiting professor today, Dr. Deidra Cruz, who's visiting from Johns Hopkins. Dr. Cruz got her MD at St. Louis University, did residency fellowship, and then has continued on until now at Johns Hopkins. She's a professor of medicine in the Division of Nephrology. She's also the deputy director of Johns Hopkins Center for Health Equity. She's core faculty at the Welsh Center for Prevention, Epidemiology, and Clinical Research. She's a senior associate faculty for the Center of Aging and Health at Johns Hopkins. She's really done an incredible amount of foundational work in health equity. She's been, core in developing the concepts and approaches to studying structural racism and the interventions and dissemination of those interventions. And the content she's worked on has really broadened over the years, of course, CKD and transplant, but also expanded to cognition, vascular disease, nutrition, and then metabolic disease more generally in terms of health equity. And then over the last years, she's expanded to supporting others in their research. She's the PI for O'Brien Center to advance kidney health equity at Johns Hopkins. She's a co-I on the Johns Hopkins Institute for Clinical and Translational Research, and of course has a huge group of successful mentees and is supported by K23. She has received many plaudits, some of which are ASN Distinguished Leader Award. She's a member of the National Academy of Medicine and American Society for Clinical Investigation. And of course, the current president of the American Society of Nephrology. Didn't realize I should have brought a glass of water up. There's too many things to list here. So just to emphasize, it hasn't shined through all these different aspects. She's just like one of the most thoughtful, generous, and inspiring folks in this field, and we're deeply appreciative of her work, mentorship, and leadership. So with that, again, an honor to have Dr. Cruz visiting with us and share your work and experience. Dr. Cruz.
Thank you. Really one of the most special introductions. Thank you so much. I really appreciate that. I have just been delighted to get to spend the last day and a half with you all and meet with so many of you. And just thrilled about the size of this crowd. I was just saying that this is really impressive, particularly for a nephrology grand rounds. I will tell my friends back in Baltimore, like, wow, they really bring out the crowd here in Seattle. So really great to see you all. I'm gonna talk today from this topic. I promised to define what's sort of meant by this concept of centering the margins. But I will I'll get through these, and I certainly look forward to your questions and kind of engagement around this area of work. So we'll move forward. So these are my disclosures. I won't, though, during our time together, be discussing any commercial products of these or really any other companies. So our learning objectives are first to try to understand this concept of centering the margins as a framework for helping us think about how to advance health equity. And we will certainly think specifically about how it can be applied to kidney health equity. We'll go on to recognize many of the profound disparities in kidney disease broadly, but and specifically around chronic kidney disease, as well as some of the societal impacts of these disparities. We'll then talk about some of the potential root causes of disparities in chronic kidney disease, and then identify some opportunities to mitigate these disparities. So first, this idea of centering the margins, it really comes out of this theory, the center margin theory that was developed and put forward by Bell Hooks, who Bell Hooks worked kind of at the intersection of race, gender, sexual identity, and class. And her book that was titled Feminist Theory from Margin to Center led to what is now known as the center margin theory. So the idea, and this sort of simple depiction outlines it, the idea is that for those who are at the center of a society, this means that they're automatically accepted into society due to things like their race, their ethnicity, their socioeconomic status, their sexual identity, their ability status, their primary language, their country of origin, or really anything else that grants them access without effort. Again, for this group of individuals, no effort is required on their part in order to remain at the center of a society's focus. Whereas those who are at the margins of a society, they are actually not automatically included in the center due to these same factors: their race, their ethnicity, their country of origin, their primary language, or really anything that differentiates them from those who are at the center. And in the case for these individuals, either they themselves or others on their behalf actually have to exert energy or effort in order for them to be placed at the center of a society's efforts. Now, of course, when we think about in the context of health and public health interventions, centering the margins becomes quite important. I think we saw that particularly in the height of the COVID-19 pandemic, where we saw that we were really required, if we wanted to address the impacts of the pandemic on the broader society, we really had to focus on many of those groups that historically have been marginalized, sort of placed at the margins, because they were having these just enormous impacts of the pandemic. And so we certainly saw that in this case we've seen in this case that bringing those who've systematically been placed in the margins of society becomes incredibly important. Now, when it comes to the impact of kidney disease on some of these socially marginalized populations, I know that you all are aware of a lot of this, but just to highlight some of the things that we know, of course, that Black, Hispanic, and Native American people have higher rates of kidney failure than do non-Hispanic white people. We know that the racial and ethnic disparities that we see when it comes to kidney health are actually not fully explained by genetic risk variants. We had a bit of a discussion about this yesterday, but I'll use as an example, again, that when we think about APOL1, and we are, of course, very excited about emerging potential therapies to treat APOL1 mediated nephropathy. I think super important to look back at those earlier studies of APOL1 that were looking at risk of progression to kidney failure, where, for example, the study that was done using data from the chronic renal insufficiency cohort, or the CRIC study, what they looked at was, certainly they did an analysis. This was published in the New England Journal. They did an analysis of those people who self-identified as being Black people that were a part of CRIC and had the high risk APOL1 gene variants. When they compared them to people who had self-identified as being white people who predominantly had European ancestry that were in CRIC, they, of course, and we know this now, they did find that the Black people with those high-risk gene variants had a greater risk of progression to kidney failure. But what I think we don't talk about enough is that in that same study, for the Black individuals who had the low-risk APOL1 genotype, they still had a higher risk of progression to kidney failure than white individuals in this analysis. And that population actually represents the majority of the people that we see certainly with chronic kidney disease. And it really speaks to the importance of us devoting time, while we're so excited about the work around APOL1, devoting time to other risk factors for both CKD as well as its progression in this population. And so as well, we also know that people with lower incomes have higher rates of chronic kidney disease. And an important challenge in our field, of course, is that it's been estimated that around 9 in 10 people with chronic kidney disease are actually not aware that they have it. And awareness of CKD tends to actually be lowest among several of the groups that are at highest or greatest risk of the adverse outcomes of chronic kidney disease, really representing a key challenge in the work that we have ongoing. This sort of cover photo was from a journal issue that Dr. Hall and I co-edited together. And I promise I'm not pandering. I didn't add this just because I was coming here. I really do use this a lot, and really enjoyed working with you, Yoshio, on this project. And so just to think about some of the more updated trends in these rates of disparities or burden of disparities that we see around kidney disease, this is a study that we did a few years ago, where we used data from the National Health and Nutrition Examination Survey, or NHANES, to look over around a 30-year period at the prevalence of CKD, stratifying by various racial and ethnic groups, as well as socioeconomic status groups. And what we found was that these gaps in CKD prevalence across different levels of socioeconomic status really persisted over these 3 decades. And we also noted that CKD prevalence had almost doubled among Mexican American individuals during this time period. So when looking back at the earliest time period of around 2003 to 2004 up until the most recent that we studied here, it was notable as well that the other racial and ethnic and socioeconomic groups actually didn't experience an appreciable increase in their burden of CKD, but the gaps between these groups had persisted. So showing there was sort of a stabilization, if you will, of the prevalence, but we still continue to have these disparities. Now, I know in this room that we can all agree that health disparities are inhumane. As it turns out, they are also incredibly costly. Here, really referring both to the human cost as well as the financial cost, the cost in dollars and cents. A study from last year published in JAMA looked at a 22-year period and found that Black people in the US experienced more than 1.6 million excess deaths and more than 80 million excess years of life loss as compared to white people. It's also been noted that about $1.2 trillion are spent annually due to the estimated combined cost of health disparities and the subsequent deaths that occur among racial and ethnic minoritized individuals. And here really believed to be due to those individuals' inadequate or inequitable care. And this is, data from Health and Human Services. It's also been estimated that about a third or 30% of the medical expenses that minoritized individuals incur are due to excess costs that stem from health disparities. And an important challenge, really, that many would argue separates us from our economic peers across the world is that the US spends less on social services than our economic peer countries. And in fact, we're the only country that spends more on healthcare services than we do on social services as a percentage of our gross domestic product. And it's really that point that people think is the reason that we don't enjoy the health outcomes that you would imagine that we might, given our kind of global economic status. Now, it's an understudied area in the sort of kidney space, but in terms of this idea of looking at costs. But this study did attempt to look at the cost of chronic kidney disease care, and this is costs that are incurred primarily via Medicare. And what you'll note, and it won't surprise you, is that as we look at people who have more severe stages of chronic kidney disease, that we see that the costs are greater. But what's particularly notable, if you focus at those who have stages 4 or 5 CKD, it's been documented here in this study that Black or African American individuals actually have a greater cost that's associated with their CKD than do other groups. And this is, again, similar to data that's been looked at kind of nationally across numerous different health conditions. Now, a number of different conceptual models have been put forward to help us think about and kind of conceptualize what the underlying causes are for why socially marginalized populations have greater risk of both kidney disease itself as well as its consequences. This is a model that I like in particular because I think it really captures 3 major basket areas, if you will, catchment areas that I think really do span most of what we see. So I'll call your attention to the far, let's see if I'm going to try out the pointer here, the far right-hand side of this this figure, where you'll see things that fall under uninsurance status or being uninsured or underinsured, where of course these individuals are going to have limited access to healthcare, including high quality healthcare, and they of course will then have a reduced both detection and treatment of some of the known clinical risk factors for developing CKD, and they can go on and develop. Ultimately, they can go on and develop CKD itself and have developed kidney failure as well as premature mortality. In the center of this figure are those challenges that can stem from the experience of discrimination. So here, thinking about both the psychosocial impacts of the experience of discrimination. So thinking here through the pathways around the experience of chronic stress. So the experience of discrimination as a chronic psychosocial stressor, which can lead to neurohormonal activation and biologic consequences as a result of that. but also thinking here about how people who experience discrimination also may take on kind of maladaptive behaviors, including those that have impacts on their health. So things like substance abuse, physical inactivity, overeating. There is a body of literature that connects those experiences of discrimination with, would say, maladaptive coping really with them, and that those can certainly have health consequences, and they can go on and develop kidney disease as well. Now, on the far left-hand side of this figure are those challenges that can stem from residential segregation. So in particular, thinking about racial residential segregation, or living in communities that are racially residentially segregated along racial lines. And here, including that those communities often then have really had disinvestment and have poor educational systems, overcrowding, poor housing, and as a consequence of less investment in things like education. People who live in these communities may have low literacy levels, which of course that can lead to low health literacy levels, and that has implications for their kidney health. We also know that in those communities there is not as much access to healthy food, and so these people living here in these communities may have poor nutrition, and again, these can all have consequences for their kidney health. In our time together today, I'll try to highlight these three areas that I'm sort of indicating here, including some of the work that my colleagues and I have done in these areas, really to hopefully illustrate these various challenges. So I provided you with that model again that I think is a good one for catching the main areas. I think increasingly in recent years, there's a great recognition that what really sits atop all that I just showed you in that previous model is the existence of structural inequities, including specifically structural racism. In referring to structural racism here, thinking about the many ways in which a society fosters racial discrimination through the inequitable allocation of resources and opportunities that are embedded in these mutually reinforcing systems. So systems like housing, access to healthcare, and food, what we, I think, more commonly think about or refer to as social determinants of health. And these, as I was saying, are sort of increasingly recognized in particular as the major cause of race-based health inequities that we see, including groups like the NIH and the NIDDK, of course, in many cases, our primary funder for many of us, have recognized this and have put forward, in this case, I'm sort of citing a workshop that was sponsored by NIDDK that I co-chaired. And out of that workshop that was looking at really thinking about interventions that could be done to address the impacts of structural racism on kidney health. What came out of that workshop was then a request for applications for clinical trials actually addressing this. And there are 5 centers across the country. I collaborate with a group that's working on one of them. But there are five sites that are conducting clinical trials right now to address those impacts of structural racism, again, funded through NIDDK. And it's specifically structural racism's impact on kidney health. So turning first to this idea of access to high quality and equitable healthcare. Of course, all of you know that in the last couple of years, our field has undergone a change in the very way that we go about diagnosing kidney disease with the 2021 equation that does not, for estimating GFR, that does not include the Black race modifier that it previously included. And certainly there's great hope that with this implementation of this newer equation that we may be able to detect chronic kidney disease earlier among Black individuals, really the group that is expected to have the biggest to feel the greatest impact from this change. I think most people would argue though that this alone, while super important, is not enough to really to address the broad disparities that we see, including in the care of people with chronic kidney disease. So one key challenge is this issue of the timeliness or lack of timeliness in which people with CKD are actually referred to folks like us in nephrology. In this study, this was with my colleague, Tangela Purnell. What we looked at was national data, Medicare data, where we were looking at a group of people who had newly initiated, had newly started dialysis. And then we looked to see if in the 12 months preceding when they initiated dialysis, if they had received nephrology care. And what we found was that Black, Hispanic, and Asian patients were less likely to have received nephrology care in those 12 months prior to getting started on dialysis, including in the most sort of the most recent time period that we had examined, Hispanic individuals being 39% less likely to have received, to have had even a single visit, with a nephrologist in those 12 months prior to needing to initiate dialysis. Now, many of you may be saying, oh, is that because of known disparities in insurance coverage? When we went on in the same study to account or address or adjust for disparities in insurance coverage, sure enough, that did attenuate this finding, but Hispanic people still in specific were 10% less likely to have received nephrology care in those 12 months. Now, what about? I know many of you work at the VA here. What about in the VA system? So in this study, what they examined was nephrology care among veterans who have CKD. And what they found, they specifically looked at veterans who had new cases of stage 4 chronic kidney disease, and they looked among non-Hispanic, white, Black, and Hispanic veterans. And what they found when they looked at nephrology care, they found actually that the Black and Hispanic veterans were actually more likely to have been seen by a nephrologist, many arguing appropriately, because these are going to be the same populations that we know through numerous studies are going to be at greater risk for progression to kidney failure and a need to initiate kidney replacement therapy. However, when they did go on to look at who actually did progress to stage 5 CKD, they still continue to see that Black and Hispanic veterans were more likely to progress, really arguing that, yes, nephrology care important, but not fully sufficient, really, to mitigate these disparities that we see. Just to highlight that. So turning to residential segregation. So what we certainly know is that residential segregation is among the most potent forms of structural racism. And practices like the highly discriminatory practice of redlining is one that has really underpinned or underlies much of what we see today with respect to structural racism and residential segregation. I think many of you are familiar, but redlining was a practice that began around the 1930s in the US, and it was the practice by which banks, insurance companies, or really others that were in a position to lend money to either individuals or to businesses would actually restrict their lending if those individuals or businesses were situated in communities that were either where the residents were either predominantly Black people, or in many cities they sort of had the same practice against religious minority groups, including Jewish individuals. And I'll first turn your attention to the map on the right, which is where I'm visiting from. So this is the redlining map of Baltimore from around the 1930s. So the area that's shaded in red was considered the area that was considered hazardous for banks to lend to, whereas the areas that are shaded in green were those considered to be the best or the optimal areas for lending, and those in blue were kind of in between. They were considered sort of still desirable, but certainly not as good as those areas shaded in green. Now, I'm sharing this map of Baltimore because in the 1930s, Baltimore was one of the first cities to actually adopt this highly discriminatory policy, such that many cities around the country actually modeled their redlining practice after what they were seeing that was done in Baltimore. And so I'm sharing with you the redlining map of Seattle, and I'm sure you all are zooming in and thinking about those communities today. But it follows a similar pattern with the red areas representing what was considered a hazardous community for banks to lend to. This is a redlining map of Seattle from the 1930s as well. So this is the area for Baltimore. So then if we look at Baltimore today, what we see is that even 5 miles makes a world of difference when it comes to health. When we focus on this community in the northern part of the city, the Roland Park or Poplar Hill community, what we see is around 83% of the residents are white people, and the median household income there, which would get you kind of a matchbox apartment here in Seattle, but the median household income there is around 104,000. The unemployment rate is very low. The homicide rate is non-existent. The life expectancy is around 84 years, which really rivals countries like Japan and other countries around the world that really enjoy much longer life expectancy than we do on average here in the U.S. The death rate from heart disease is pretty low in this community. Whereas then if you turn your attention to the Madison or East End community in Baltimore, what you see is that around 90% of the residents are Black or African American. The median household income is about a quarter of what it is in Roland Park. The unemployment rate is more than 10 times what it is in Roland Park. The homicide rate is high. The life expectancy is actually 15 years less than what it is in Roland Park. And the death rate from heart disease is more than 3 times what it is in Roland Park. And you'll recall that that was the same area in the previous map that I shared with you that had been redlined now nearly 100 years ago. And so in some recent work, I was really excited to collaborate with Dr. Kevin Nguyen, who is based at Boston University, and others on this study where we looked at historical redlining and present day kidney failure in U.S. cities. And we were really fortunate to have a wonderful editorial written about our article by Dr. Rodriguez. Thank you. But I'll share with you what we found in this study. So we focused on adults that were living in 141 different U.S. metropolitan areas between 2012 and 2019. The primary exposure that we were interested in was their present day sort of living in these communities that had been redlined now about 100 years ago. And the outcome we were interested in was the kind of annual census tract level incidence of kidney failure in those communities, again in present day. And so what we found was that living in these historically redlined communities was associated with a significantly higher rate of kidney failure as compared to those who lived in communities that had been given that grade A, or those green shaded communities on those maps that we looked at. We importantly found that this was true for everyone, regardless of their race or ethnicity. So this living today in a redlined community was associated with a greater risk for kidney failure, regardless of really what that the individual kind of race or ethnicity was, or or what the community level, if you will, kind of race or ethnicity was. It was really bad for everyone if they lived in those communities. Now, we were, of course, interested in how this living in a redline community today might look, how that might be impacting groups that have pretty significantly greater risk of kidney failure in present day. And so we really did zoom in on Black individuals and found that for Black people, and that's the last bullet point here, that relative to Black people who lived in communities, who live in communities today that were given that grade A or desirable, that were marked as a desirable area for lending, those Black people who today live in what had been redlined communities were significantly greater risk of having kidney failure. Again, underlining again, not all genetics, right? So this is just showing here that this environmental or the exposures that can come with living in these sort of communities certainly seems to be underlying some of what we see in terms of the greater burden of kidney disease among Black people in this country. So of course, residential segregation and the sort of impacts of discriminatory policies like redlining certainly shapes a number of different aspects of everyday life, an important one being housing. So in this sort of review article led by Tessa Novick, what we were looking at is really all the different things that can shape the housing status of people, particularly thinking about people who may have kidney diseases, and thinking about things like the policies like redlining, as well as policies around single family housing, Medicaid expansion, and how that might impact the financial status for people, as well as thinking about community level factors like just the affordability of housing. I'm aware that here in your great city that is thought to be a driver of some of the housing challenges here. We also here highlighted that at a community level that employment opportunities can play a role, as well as other factors. certainly at an individual level, these policy and community factors then influence things like mental health problems that could play a role, the experience of violence, adverse childhood experiences as well can occur more often in people who are living in sort of poor housing conditions, and certainly all of these factors then can really contribute to this quite vicious cycle where having unstable housing can make a person then have an inability to pay for or kind of engage in their medical care and healthy behaviors, and they can ultimately have poorly controlled chronic disease, go into having an inability to work, and then the cycle really just does continue. So we were interested in how housing instability may impact the amount of healthcare engagement that people who have chronic kidney disease may have. And so we focused here on a Baltimore-based cohort called the HANDLE study, which stands for the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study. Really quite a mouthful, but HANDLES for short. And we focused on a group of participants, around 350 of them who have chronic kidney disease. And what we're interested in is their responses to the questions of, are you able to afford a suitable home for you and your family? And the question of, have you had difficulties making rent or mortgage payments? And so based upon their responses, we found that a little over a third of them were experiencing housing instability. And then what we did was then to examine the question that had been asked in the context of the HANDLE study around whether these participants had postponed seeking medical care when they otherwise felt like they needed medical care. And what we found is that indeed people who were experiencing housing instability were more likely to have postponed seeking medical care when they otherwise felt like they really did need medical care. And we found that this was a sort of that having housing instability was an independent predictor of having done that. You can see as we accounted or adjusted for a number of different factors, that group was still 60% more likely to have postponed seeking medical care. So that was a small kind of sample. We were then really excited to be able to gain access to, as non-VA employees, to be able to gain access to some VA data to be able to look at this question of unstable housing among a group of U.S. veterans receiving dialysis. So here, again, work led by Dr. Novick. What we looked at was a group of veterans who had recently who had initiated dialysis, and then we looked back and we tried to leverage the fact that in the Veterans Affairs system that there's a robust system for screening people for basic needs like housing. And we were able to kind of look back in the few months preceding when they initiated dialysis to see if they had indicated that they had unstable housing. And then we then looked forward to look at their outcomes and found that particularly for older veterans, so those between the ages of 75 and 85, that if they were experiencing unstable housing in those months preceding initiating dialysis, that they had a greater risk of mortality than did those veterans who had stable housing. Now, another factor, very important for health that has been shaped by historical practices such as redlining, is this idea of neighborhood food availability. You can tell that I enjoy maps if you're if you're following along. I really do. And so this is a map of Baltimore. So this box here represents Baltimore City, and the area outside of it represents Baltimore County. And what's indicated here, and this is some work by colleagues at Johns Hopkins. What's indicated here is what they did, I should say, what these colleagues did was they sent out every 2 years, we have the center at Hopkins called the Center for a Livable Future, and they send out these, every couple of years, they send out a group of enthusiastic research assistants who go to every food outlet in Baltimore City and in Baltimore County, and they assess the presence or absence of healthy foods in these stores. And what they found that's indicated here in this study was that there was a greater amount of healthy food available as indicated by the size of the green circle in those communities where the majority of the residents were white people. So as noted by the darker gray shaded communities, as compared to those communities where the residents were predominantly Black people. So as indicated by the white shaded areas. They found also similar findings along economic lines with those communities that had a higher median income having a greater amount of healthy food available. And this type of finding won't surprise any of you probably, and it's also been replicated in a number of cities across the country. So we know that as well that a related but distinct in many ways challenge that many socially marginalized populations experience is that of food insecurity. So one definition is that it's the inability to afford nutritionally or to obtain nutritionally adequate foods in safe ways. We know that around 44 million people in the US are food insecure, including 13 million children, and 100% of US counties actually have people living in them that are experiencing food insecurity. So it really is quite pervasive across the country. In work with Dr. Tanushree Banerjee, who is at UC San Francisco, we looked at the relationship between food insecurity and subsequent progression to kidney failure among people with CKD. So using data, again, from NHANES and National Health and Nutrition Examination Survey with linkage to Medicare data, we kind of characterized a population of NHANES participants who had CKD at their NHANES enrollment or assessment. And then they also, a lot of people, I think, forget that NHANES is a nutrition study. So it has a lot of nutritional data, including questions about food insecurity. And so we kind of leveraged that data. And what we found is that those who were experiencing, those people, again, with CKD, who were experiencing food insecurity over 9.5 years of sort of follow-up and linkage to Medicare data, that group was more likely to develop kidney failure than were those who were food secure. Now, when we went on and we, again, accounted or adjusted for different factors, I think we were encouraged in many ways to find that when we accounted for nutritional factors, we were actually able to explain away, at least statistically, this association between food insecurity and progression to kidney failure. Really highlighting that despite the fact that what the literature would suggest is that people who are experiencing food insecurity, and when we assess that they're experiencing food insecurity, what we're really doing is of course, those are done in like one time point and can represent trade-offs that they're making. So if someone says yes, that in recent months they've been skipping meals because they didn't have enough money to buy food, it could be because they were using that money to pay for their medications or their utility bills, right? So even keeping in mind that food insecurity itself may be a marker of other types of financial resource strain, this analysis at least suggested that if there was a way to intervene upon the dietary practices and factors for these individuals, we might be able to mitigate that progression to kidney failure. So this work was coming around for us at a time when we were also doing some other studies, really trying to understand the types of dietary patterns that can portend better kidney health, right? So thinking about both new development of CKD, as well as what types of dietary patterns might be associated at least with a lower risk of progression to kidney failure. And I'll give you the take-home message. I got to work with some brilliant colleagues around this, but the take-home message really was that dietary patterns rich in fruits and vegetables, whole grains, low-fat dairy foods, similar to patterns like the dietary approaches to stop hypertension dietary pattern, the Mediterranean dietary pattern, as well as those patterns that are low in dietary acid load. So dietary patterns that present less acid for the kidneys to handle are associated with more favorable kidney health. So both from an incident chronic kidney disease standpoint, as well as progressive CKD standpoint. And so that's basically what this sort of body of work pointed us to. And so really to think about then how we could have an impact on health disparities, we decided to center marginalized Black or African Americans who have kidney disease risk in the work that we were to conduct. We thought we would first start by asking such individuals about this idea. We wanted to focus again on nutrition. We recruited a group of Black individuals who had a first-degree family member treated with dialysis. And we asked, and these individuals, these participants in our qualitative study were also people who had low incomes and themselves had clinical risk factors for chronic kidney disease like diabetes, obesity, hypertension themselves. And so this was work led with my mentee at the time, Dr. Amber Johnson. She's now a cardiologist. For a time in our residency program, I was known as a direct path to cardiology. I know, it's very sad. But there were a lot of people who came to me as a med student or resident en route to become a cardiologist, but we can talk about that another time. But she was one. She's been very successful, but that was her path. So as a resident, Amber worked with me on this project. And what we found, again, it was qualitative. So we were doing these focus groups. And some of the participants highlighted a number of different themes, so including that healthy foods are expensive and unavailable in certain neighborhoods. One of the participants said in our study that, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. So they were really kind of highlighting what they thought was a key barrier in their community. They also noted that the participants noted that unhealthy foods are more convenient to prepare or to access, and that unhealthy dietary practices have been a lifelong habit that they felt would be really challenging for them to break. Now, in a subsequent study, we applied a participatory research approach that's called photo voice. Show of hands of anyone who's heard of photo voice in the room. Oh, wow, more than my usual sort of response to that. Okay, so as I mentioned, so photo voice is this participatory research discipline where the study participants are trained to take photographs of something in their environment. And then what they do is then bring back, after developing the photos, they then come back together and discuss what's seen in those photos. And it's really used as a way to in a more qualitative way or sort of a narrative way to put together what individuals are experiencing. And then it's often used in advocacy work. It's actually often used to then say, as a community, this is what our needs are based upon what we're showing you. We saw in these photographs. And so in our case, what we did was to recruit a group of Black adults who all have hypertension. Many of them also have chronic kidney disease. They had actually kind of just missed criteria to be in a subsequent study that I'll tell you about in a few slides, but we wanted to engage them in this way. And so they took various photos. In this case, P. Mosley took this photo that was on the left and said, this vacant building, now people start sitting and drinking in front of it. This is an eyesore. People leave trash, which attracts rats. This building could be turned into an Aldi's, which is a grocery chain near us. Discriminatory practices against Blacks don't allow them to buy lots and buildings. It's not affordable to a lot of people, so they give up. People want to do good, but don't have the money. We can have liquor stores, but not a market. This is really what they were seeing there in their community. Now, I've shared with you a lot of real challenges, barriers to healthy eating. I also want to certainly uplift some of the assets that we've identified, especially in our community-based and community-engaged work, including this work, including this effort and this quote from Mr. Davis, who was a part of our photo voice study. And he had actually established his own home garden to really try to overcome some of what he was seeing in terms of the lack of healthy food available in his community. And he was, of course, growing food for himself and his family, but also sharing it with neighbors, really to try to overcome these barriers to healthy food access. So he said, I tried something I saw out at a store at home. It saved money and it was good. It's complicated to try shopping. People with cars can get around. People in the neighborhood have no access. I try to help when I can. Concerns about crime and safety. If it was easier to get stuff, crime would decrease. And so this was sort of his effort to address these challenges. In recent time, we have wrapped up a clinical trial that attempted to overcome some of these real world obstacles to healthy eating that are particularly experienced by Black Americans living in some of these residentially segregated communities. The trial was called the 5+ Nuts and Beans for Kidneys trial, and it was a 12-month, 2-phase community-based study where we enrolled 150 Black Americans who all had a diagnosis of hypertension, and they all had albuminuria, so an albumin to creatinine ratio of at least 30. And a GFR also of at least 30. And what we hypothesized in the study was that delivery of nutritional advice to adopt a DASH-like diet, so dietary approaches to stop hypertension, sort of like dietary pattern, plus the provision of $30 a week worth of potassium-rich foods would lead to a 20% greater reduction in urinary albumin excretion, as well as improvements in blood pressure when compared to a group that received a grocery gift card alone without nutritional advice. And we presented this the first 4 months of the study at Kidney Week in the high impact clinical trials, and then as we've now completed the full 12 months of the study, the full manuscript of both phases is in progress. And so this was a community-based participatory research study where we had numerous partners and stakeholders that were engaged with us, including our grocer partner, ShopRite, as well as a highly engaged community advisory board that's featured in the bottom right-hand side. So I'll share with you the phases of the trial. So after randomization, the participants were randomized to one of two groups. So on the top section here was our self-directed, or S- diet group, as we referred to them, where in the first 4 months of the study, they received a gift card that was worth $30 a week, and they were instructed that they could use that at ShopRite. ShopRite has they have several stores in Baltimore, but a couple that we really pointed the participants to where they could shop either in person or online using that gift card fund. So really it ended up being $480 worth of funds that they could shop with. And they also received our study coach, our health coach that worked with us in the study, at randomization, reviewed the DASH diet with him, gave him a pamphlet, a very sort of light touch with respect to the DASH diet information. But then in the second phase, the last 8 months of the study, they did not receive the gift card, and they were told, please just follow what you read in the brochure about the DASH diet. Whereas the coaching DASH group, here on the bottom, the dietitian-directed coaching group, in the first 4 months, they received assistance with ordering $30 a week worth of these 5+ foods, as we refer to them, that were delivered to their home by a courier. And they also received brief weekly phone calls with our study coach, wherein in the calls they would review the foods that the participant had consumed in the previous week, as well as place their order for the next week. And then in the second phase, the last 8 months of the study, they did not receive the weekly food allowance, but they did continue to receive telephone calls or visits that were spaced out, not on a weekly basis, but every 2 weeks initially, and then once a month for the remainder of the trial. This is and I'll share with you the 4-month kind of results today. So this, just to give you an idea of some examples of the types of potassium-rich foods that we were providing to the participants, and they could select from about 60 different foods each week that they could choose from. You can see the potassium content of these foods. And our targets were really to have the participants consume 5 servings a day of fruits, vegetables, nuts, and beans. And we during the weekly orders, we would order for them 17,000 milligrams worth of potassium. So that we had a very complex Excel calculator that would help us to sort of get at 17,000 milligrams of potassium, but also less than $30, or sort of right around $30. That $30 amount, if you're wondering why that amount, it really came out of at the time when we were first establishing this trial. That was about the amount of the weekly supplemental nutrition assistance program benefit on a weekly basis. It's gone up a bit now, but that was why we chose that $30. With the sense that we were not looking to replace 100% of the calories that they were taking in, but to sort of to add to what they may be consuming, including food that they may have been purchasing using the SNAP benefit. But that's where the $30 comes from. So then this is just an example of when we would have there's some of our study staff, but when we would prepare those bags of groceries that then the courier would sort of come and pick up for them to deliver to the participants' homes, we would include tip sheets in those bags, including this one, how to eat 5+ for folks who don't cook, because some of what we'd found in our qualitative work, there are a lot of people who said they just don't cook at all. And so we knew that to have an intervention focused on the diet, especially encouraging people to consume foods that maybe they don't typically consume, that we would need to guide them on how to incorporate them into their way of eating, even if they don't cook. And so the main conclusions of our trial were that coaching to follow a DASH-like dietary pattern, plus the provision of healthy food, led to significant within-group improvement. So the group that received the coaching, when we compared them at follow-up to their baseline, this is the 4-month results here. When we compared them at 4 months to what had been their baseline at measures, we found these significant improvements in diet quality as well as albuminuria. So in terms of the % decline in albuminuria. And we found that coaching was superior to the food subsidy alone for improvements in diet quality overall. So things like number of servings of fruits and vegetables, the amount of potassium, urinary potassium that they were excreting. So really indicating that they were taking in these additional fruits, vegetables, nuts, and beans. But we found that improvement in diet quality for that group, as well as albuminuria lowering, specifically for those who had very high albuminuria, so who had ACRs of at least 300. So really highlighting that for that population, I think many of us would be concerned about their risk of progression to kidney failure in particular, that this intervention seemed to have a significant impact. And again, we're finished. We are working on getting the full paper published. So stay tuned for that. But all the way through 12 months. This is the four-month data. So one of the things that's been really important here, just to wrap up in the last couple of minutes here, one thing that's been really important is, as many of you may note, a lot of what I've been talking about this morning are the solutions to these problems really would have to happen in order to be quite broad scale, would have to happen at a policy level, right? So either kind of little p policy, like at a health system level or payer level, but also at a big P level. So thinking about public health and public policies. So we've certainly tried to advocate for these sort of policy changes, including, I mentioned the Photo Voice project that we did. We took those photographs and we actually had a kind of a expose of those photos where we had a symposium called Seated at the Table, where we brought in policymakers and educators, urban farmers, like people who are invested in the food environment in Baltimore, to talk about ways that we could reshape the food environment in our city. We've also, specifically in the kidney space, with just some wonderful colleagues, have tried to advocate for changes that really could shape the way that we support people living with kidney diseases, particularly who may have various basic needs, like around housing, including a call in the article that was about dialysis for patients with end-stage renal disease who are homeless, where we really were calling, and that was in JAMA Internal Medicine. Really, there we were calling for consideration for permanent supportive housing for dialysis patients who are experiencing homelessness, similar to the program that exists for people living with HIV. Certainly, we would argue, and we did in that article, that when we think about the investment that we're making from a Medicare standpoint to those individuals, that it should behoove us to think about making sure we're meeting the basic needs that these individuals have, so they can actually get to the treatment that we are already, as a society, right, invested in. And so these are some of the avenues that we've tried to use to call for these types of policy changes. So I will summarize to share that certainly disparities in CKD are profound and have significant societal impacts. Some of the root causes of these disparities include limited access to high quality healthcare, discrimination, as well as the numerous downstream effects of residential segregation. And in my view, achieving kidney health equity is going to require us to commit to centering the margins by designing interventions and advancing policies that attempt to draw upon the strengths as well as address the needs of a number of these historically marginalized communities. And so I want to acknowledge the participants of the studies that I presented today, as well as my colleagues at these various centers, and to particularly highlight the last one. Some of you heard that we now have a new Johns Hopkins O'Brien Center to Advance Kidney Health Equity that is serving as a national resource for people who are trying to conduct work, both basic and clinical research, that is either attempting to understand the underlying mechanisms or to look at ways to mitigate these disparities. So feel free to reach out to us if you are looking to do that kind of work, and we would certainly love to partner. I will end there, and thank you. Questions? Dr. Bullock.
Hi, I love this work. I have a comment and a question. So the comment is, I really admire a lot of the nuance that you have within the food sort of interventions. Because I think so there's this organization here in Seattle called Clean Greens, which basically is a Black-owned nonprofit whose goal is to increase food access through like community supported agriculture. And like a side note for anyone, if you have patients who need vegetables, would benefit from like a weekly food like veggie bag, then they can do it. I think one of the challenges is that some people, like the vegetables that people have, like they may or may not actually like them, or typically incorporate them into their diet. Like I think this particular organization is very sort of like oriented towards that, whatever this means, typical African American diet. But yeah, I like that you all like let people. It sounds like you let your participants
Choose,
choose. My question is, I'm curious to hear your perspective on the like DEI landscape that's happening right now, and how that's influencing the research, the policy that's happening, the ASN level. If there's like practical strategy that you would recommend that people think about right now with the wave of legislation that's happening.
Well, thank you. Thanks for that. I would, so I want to make a comment about your first comment, and then I'll tackle your second comment. So your first comment, I think, is interesting. One of the things we would certainly advocate for is definitely choice. So making sure that people have autonomy around the selection in these programs that many people around the country, I think there needs to be more, but that many around the country are trying to set up. We certainly would argue for that, as well as guidance around both what foods would be supportive of particularly the chronic health conditions that they may have, and guidance around preparing them, right? So I just a note on that. As far as the conducting this type of work in the landscape of what we're seeing in terms of some pushback, I think particularly around workforce diversity, equity, and inclusion, I would say one of the key things that we've tried to do at ASN, and one that I advocate for strongly, is that we not conflate workforce diversity, equity, and inclusion with health equity efforts. They are not the same. And I think a lot of times they're almost, you listen to some people speak, they almost put them in the same, that the words sort of almost get garbled together. They are not the same thing. I've written, if you want to read more about my views on this, wrote an article a couple of years ago that was in JAMA Health Forum about how we need to disentangle these two concepts. Having said that, one of the things that you mentioned or had a question about ASN. So we have separate activities around this. So we have a diversity, equity, and inclusion committee that is pretty long-standing now, that is focused on the workforce questions and challenges here. And we separately have a healthcare justice committee that is focused on the health equity and healthcare justice, sort of piece of that. And that's very intentional. And so I do think as those that are advocating really for both of those spaces, really being clear about what we're talking about when we're sort of making recommendations. Now, the two have implications for each other, for sure. And often people who can work, there are people who have expertise that can apply to both areas, but I think really important to just be really clear about about what we're working on. And I think we have to find new ways to address these sort of challenges. I have to, with Dr. Marotra here, I have to mention an article that I recently wrote about how, our way, in my view, the way that we can pursue continuing to advocate for diversity, equity, and inclusion in nephrology, even in the setting of the Supreme Court decision that is in CJSON. And so if you want to read more about my ideas around that, I think the work has to continue. We just have to get, just as those that are opposing this work get more nuanced, I think we also have to as well. We have to be nimble, but it's too important. It's too important for our ability to address health equity and kidney health equity. So we have to really think of new ways to continue to promote diversity in our field. So I could talk about that for a long time, but that's so. Other questions? Yeah. Sure. Sure.
At the end, you talked about coaching having an impact, and I'm wondering whether there's an additional element of isolation that has developed over time, particularly in unrelated to COVID, that we're seeing amplified in populations, both urban and rural, that are experiencing this period.
Yeah, thanks for that. I do wonder about that, and how much I think that just the impacts of the pandemic and its mitigation efforts specifically have affected people in such different ways, right? So for many of us, we had the luxury of being able to work from home, and maybe pick up a new hobby. I was sharing that, my husband decided he was going to build a bike, but it's like, how privileged is that? That's he's going to build a new bicycle and become a bike, a biker during the pandemic. But lots of people had to go into work, and so I think it has impacted people in very different ways. And I think it is a worthwhile area for us to study, like how we know. Well, there are groups that are beginning to understand more and more about kind of the biological impacts of COVID infection including on kidney health. And I think we're going to see that it is a risk factor for progressive kidney disease. And we will, in years to come, it'll be on that list of things that we're going to want to kind of adjust for, even though I think most people will have had have had COVID infection at some point. But I think we're going to have to figure out ways to account for, like, when it was severe and whether that's showing up in what we see. But I think from a psychosocial standpoint, I think you're absolutely right in terms of those, like, social connections and how they certainly can have health impacts. I think we're going to need to try to study that, understand how that may have impacted some of these same populations that we'd be concerned about for their for regarding health disparities. So I don't have an answer, but I definitely think it's an area we should invest in. Yeah. I don't know which one went first. I'll let you.
Okay. I want to follow up on Justin's nutrition comment.
Sure.
Question about 5+ and means. And I was wondering how it's great to see trials in that area. How did you deal with individual level versus household level intervention?
Sure.
Did you include big groups and individuals? What about people who were cooks or cooked for? Things would alter your approach.
Yeah, so thanks for that. So we focused on the individual. So again, thinking about how what we were the people we were recruiting were people, so Black adults with hypertension with albuminuria. So we had to enroll them at the individual level. Now, we presumed that people, especially if they lived in households where they had multiple individuals in the household, that they might share some of their food. So we did a couple of things. One, we did capture that data, so we know how many people were in the household. We also gave them these heavily branded bins, for their food. And we sort of instructed them, please tell your family, this is your food for this study. This is for you. And we tried, but in the weekly calls with the coaches, we actually captured how much of the food they ate. So the coach would say to them, okay, last week you ordered grapes. How much of the grapes that you ordered did you eat? Did you eat none of them, a quarter of it, half, et cetera, right? So we were able to get at how much they did consume. And we did see, as I mentioned, we did see this both self-reported increases in fruit and vegetable intake, as well as objectively changes in urine potassium. So it did suggest that they were consuming the foods. But you're right. We do expect that some people were sharing. And groups, teams like Don Wesson who's based down in Texas, and some of their trials that they've conducted, they've actually, in partnership with local food banks, they provided food for the whole family. Now, the food banks were providing the food. In our case, we were purchasing the food from I call them our grocer partner, and they were a great partner, but we were also driving business, for them. And so we were, from a grant standpoint, we were restricted in terms of the funds that we had. It's a great question. Let me come to you.
Sure.
Thank you.
So I've heard that assessment of social determinants of health will be included as a quality metric.
Sure.
Is that true?
Coming, yeah.
And what are they going to measure, and what are the actions going to be from
Yeah.
those measures?
Yeah, so there's an initiative to have these, particularly some of these basic needs, included on the Form 2728. I think one of the looming, so right now, many of you may know, we do not capture this at all. We have no idea on a national basis how many people are experiencing housing insecurity, for example, despite the fact that we encourage people to dialyze at home, but we don't know if they have a home or sort of a stable home. And so this is why I mentioned how excited we were about the VA data, because really that's the only place that we think we provided the first national estimate, of the burden of housing insecurity among dialysis patients, because we don't capture that. I think while many people would argue we won't be able to get the resources to address these issues until we can document the burden, but facilities are already, especially dialysis facilities, are already saying, well, okay, yeah, we could capture it, but then we may not have what are we going to do with that? And I think that's going to be where we're going to all need to do some advocacy around things like, well, do facilities that are caring for large numbers of patients who have these different social needs need additional support, right? So yeah, I think that is to come. But yes, it is on the horizon. Yeah, yeah, the first step.
Just one more.
Good. Okay, yeah, Dr. Moore.
Can you talk a little bit about how when you have positive results,
Uh-huh.
like the coaching study, which is very likely going to produce positive
Mhm.
results, is getting buy-in for implementation
Mhm.
of health. Nutritionists and dialysis centers saying, of course, coaching, you can do this, but gosh, I think you're changed. I gotta change the way I take care of my patients. I gotta call. You've got the data to prove it, and then you gotta change the behavior.
Yeah.
System behaviors. What advice do you have to influence to move to that?
Yeah, no, thank you for that. So a few things. So I think the implications of our study, I think, can be taken in context also of work that others are doing. So around a couple of areas. So one would be this idea of, let's take people who are receiving the supplemental nutrition assistance program benefit, the SNAP benefit, or previously called the food stamp program, right? There are a number of groups around the country that have been studying ways to incentivize healthy eating for people who, due to their income status, they are candidates for that, for the SNAP benefit. So things like, well, what if we give people an extra $5 a week, but we say they have to use that on fruits and vegetables? First, will they use it on fruits and vegetables? And second, will it have health implications? And we would argue that our study argues that the food provision isn't enough, that you also need to give people guidance on what to purchase. Like right now with the SNAP benefit, there's no guidance. It's just, here's the benefit, but there's no guidance. You could have all the chronic health conditions that we could think of, but there's no guidance about what you should purchase. We would argue that should be the case. So thinking more at that really federal policy level is where we're hoping to kind of inform things. Now, at a healthcare system level, we do hope to ultimately do some cost analysis here to sort of look at what is the cost of having a coach who's calling this frequency, the cost of the food, et cetera, to be able to provide that kind of data to a health system that may be trying to look at this. We don't expect them to do it broadly, but maybe they want to focus on their high healthcare utilizers. There's some evidence. There's a colleague who's at UNC Chapel Hill, Seth Berkowitz, who does a lot of work around food insecurity, who they've done an analysis in North Carolina showing that for older adults who receive the SNAP benefit as compared to those who don't receive it but are eligible, the Medicare and Medicaid expenditures are actually less, and they have less sort of healthcare utilization. So that, putting the evidence together in that way, I think is going to be the way to make that case. So, but it's a long road, but I'm grateful that we're not the only group that's trying to look at these kind of things. Yeah.
Well, thank you so much.
Thank you.